Our next speaker is Dr. Rebecca Thurston. Dr. Thurston is the Pittsburgh Foundation Chair of Women's Health and Dementia. She's also professor of psychiatry, psychology, epidemiology, and clinical and translational science. She's also the director of the Women's Biobehavioral Health Program at the University of Pittsburgh. Dr. Thurston is an expert in menopause, the menopause transition, and its implications in women's cardiovascular and brain health. She's the PI of the Miss Heart and Miss Brain studies, and these studies leverage actually wearable technologies, some of which we were talking about during this meeting, to investigate links between menopause, cardiovascular disease, and the aging brain. She's also the PI of the study of women's health across the nation, which is a longitudinal study that is greater than 20 years in its tenure and will provide seminal information about the menopause transition amongst racially, ethnically diverse cohorts of women. Dr. Thurston is also a past president of the North American Menopause Society, and in addition to all that, actually works as a clinical psychologist, a busy clinical psychologist at that. With that, please welcome Dr. Thurston.
Thank you so much for that kind introduction. So today I will be talking to you today about hearts and minds, the importance of menopause for women's cardiovascular and brain health. All of this work is funded by the National Institutes of Health, and here are my disclosures. So the menopause transition is a universal transition. All women living long enough will go through it. It happens in the 40s and 50s, accompanied by menstrual cycle changes, pronounced hormonal changes and fluctuations, and characteristic symptoms such as hot flashes, sleep problems, mood changes, all of which have implications for women's hearts and brains. So cardiovascular disease is a leading cause of death among both men and women. And cardiovascular disease in women has some unique features. One is an important role for reproductive and hormonal factors. We know a lot of folks here at MWRI do a lot of work on pregnancy. I'm at the other end of the spectrum, focusing on menopause. And the menopause transition occurs directly before the onset of clinical cardiovascular diseases. And many of clinical cardiovascular disease events, particularly MIs, happen about a decade later in women than among men. These events are relatively rare premenopausally, but risk accelerates during the peri and postmenopause to ultimately match that of men. So menopause is seen as a time of accelerating cardiovascular disease risk. So here is a little bit of a busy slide, but here's the average life cycle of a woman. And you can see in the red that many of those cardiovascular disease events accumulate during that postmenopausal period there in the blue. So just to define some terms here, the premenopause is a time of regular menstrual cycling, reproductive viability. And when you start getting irregular menstrual cycles, oftentimes in the mid to late 40s, you enter into the perimenopause. And the perimenopause is divided up into the early perimenopause, where you have menstrual cycle irregularity, and the late perimenopause, where you have menstrual cycle skipping. After you've had 12 months of amenorrhea, you enter into the postmenopause. And on average, in a population standpoint, 51 is the average age of that final menstrual period before those 12 months of amenorrhea. And as you can see, many of the cardiovascular disease events accumulate after this time. And here are some data from the study of women's health across the nation, looking at changes in carotid atherosclerosis. So these are change scores on the y-axis. And you really see this uptick in the green during the late perimenopausal period in the accumulation of underlying atherosclerosis. And this is adjusted for age. So it's not all about somatic or chronologic aging. You also get this role for reproductive aging and women's vascular health. And I'm here to tell you, I can show you some data, I'll show you in a couple minutes, but hormones don't explain the whole thing. Oftentimes when we think about menopause, the first thing people think about is the loss of estrogen, and it must all be about estrogen. Well, I'm here to tell you it's not. And there are some other things going on. So one of these things are vasomotor symptoms. These are our hot flashes and night sweats. Upwards of 70% of women will experience vasomotor symptoms during the menopause transition. And for about a third of women, these symptoms are very frequent or severe. And these frequent or moderate to severe hot flashes, we used to think they lasted maybe 3 to 5 years around the final menstrual period. They actually last more like a decade for many women, and a quarter of women for much longer than that. And in fact, because this really challenged our notion that vasomotor symptoms were such benign time-delimited events, this work was actually picked up by the New York Times and got quite a bit of press. What's the physiology of vasomotor symptoms? These are a central nervous system event. And we've really made a lot of strides recently about what is the underlying neurobiology. And this is happening at the level of the hypothalamus. The hypothalamus houses our master controller of the reproductive axis, so our GnRH pulse generator. It also houses our thermoregulatory centers of the brain. And those hot flashes, those sweating events, are really thermoregulatory events. And right out of called the candy neurons, there's this crosstalk between the reproductive endocrine centers and the thermoregulatory centers. And we have a new class of agents, not yet FDA approved, currently in a study aimed directly at this neurobiology. So stay tuned. So vasomotor symptoms have important impacts on quality of life. They influence mood and sleep and functioning, and are a leading cause of treatment seeking among midlife women. This is what oftentimes brings those menopausal women into the office. But do they have implications for physical health? And we started to ask this question because 2 of our large hormone therapy trials, the WHI and HERS, started to show us that there was potentially something different about the underlying vasculature among these women with vasomotor symptoms. They both showed effect modification by vasomotor symptom status of that relationship between hormone therapy and cardiovascular disease risk. So we wanted to understand, what do these vasomotor symptoms tell us about women's vascular health? And we started by asking these questions in the context of SWAN. So SWAN is a large longitudinal cohort study of women transitioning through the menopause. It was set up in the mid-90s. It recruited women between the ages of 42 and 52, and we have followed these women to this day. So 3,300 women were recruited across 5 different racial ethnic groups, 7 different clinical sites. Pittsburgh is both the clinical site, and I'm the current PI of the clinical site, but we also have the data coordinating center here. So Pittsburgh has a lot of SWAN action going on. And this has provided some seminal information about the natural history of the menopause transition and what it means for women's health. And so we're really started by looking at subclinical cardiovascular disease, and we use several different ultrasound-based measures. One is flow media dilation. This is measuring endothelial dysfunction. So the vascular endothelium is that single cell layer lining the vessel, very important to multiple aspects of vascular tone and health, and it's one of the first things to go in the atherosclerotic process. Also, we measure carotid intima media thickness. This is measuring the thickness of the intimal medial layers of the carotid artery. You can also measure plaque in this vessel, and we do both of these things, and these measures are well validated and widely used measures of subclinical cardiovascular disease. And in midlife women, we measure subclinical cardiovascular disease as opposed to clinical cardiovascular disease because women start getting those heart attacks and strokes 65 plus. So when we're studying midlife, we're using these kinds of measures. And it also tells us what's going on the vasculature before clinical disease is present. So what did we find? So for FMD, lower is worse. So we found that women with hot flashes have significantly lower FMD, poor endothelial function, than women without hot flashes. You control for all of your standard cardiovascular disease risk factors in these models, as well as endogenous estradiol, or FSH. For IMT, higher here is worse, so more atherosclerosis. We see that women with more frequent hot flashes have significantly higher IMT, again controlling for our cardiovascular disease risk factors, as well as our endogenous hormone levels. So this was very intriguing early data. However, there were some limitations to our epidemiologic work. One is that our hormone measures, while really good at the time that SWAN was set up, we know we can do better. We have more ultrasensitive mass spec measures now that have since come down the pike. But most importantly, when we're studying these huge numbers of women, the best we can do is essentially give them a questionnaire. And how good is that for really assessing physical symptoms? We know we can do better. We have ambulatory, objective measures of hot flashes. We also want people reporting those symptoms at the time that they're having them, not trying to recall them weeks or months later. So we use these wearable technologies. And we set up a study of 300 women here in Pittsburgh who were between the ages of 40 and 60. We had them undergo a range of different study measurements, including wearing our hot flash monitors. And this little graphical thing here, that is a hot flash coming out of one of our monitors. We also give women an electronic diary to fill out at the time that they're having hot flash. We send them out into the world. They come back 3 days later. We take this equipment. We do an ultrasound of their vasculature, and we also do a blood draw, and we get those mass spec hormones and certain cardiovascular disease risk factors. So what did we find in Ms. Hart? So among the women who reported having hot flashes, the more hot flashes you had, the higher your carotid atherosclerosis. In the red, they can measure them physiologically. In the blue, self-report. These are quartiles of hot flashes. Basically, we saw this beautiful dose response. And this is controlling for blood pressure, lipids, medications, et cetera. And in fact, these hot flashes accounted for more variance in IMT than pretty much anything else in the model, with the exception of race ethnicity. So we would argue this is not only statistically significant, but clinically significant. Similarly, we're measuring carotid plaque. We were surprised to see that half of these women had carotid plaque. They were in their mid-50s, and we saw, again, this kind of dose-response relationship between the hot flashes and the carotid plaque. So what are the underlying mechanisms? We did a deep dive into hormones. We got mass spec estradiol, estrone, testosterone, SHBG, the protein that binds E2 and T. These hormone indices were weakly related to the vascular measures and did not explain the relationship between the vasomotor symptoms and IMT. We did a deep dive into our cardiovascular risk factors, blood pressure, obesity, insulin resistance, lipids, lipid subfractions. These were not this story. We measured CRP, IL-6, a whole bunch of clotting factors. This was not it either. And then we also had 24-hour EKGs on these women at the time that they're wearing the hot flashes. And from a 24-hour EKG, you can get a measure called heart rate variability or respiratory sinus arrhythmia, which gives you an index of parasympathetic or vagal control over the heart. And lower here is worse. And we were able to plot in a minute-by-minute fashion during that hot flashes. During each hot flash, you have this acute reduction in cardiac valve control, or respiratory sinus arrhythmia. And we've replicated this now in the home, in the laboratory, multiple different groups of women. It doesn't matter whether the woman feels the hot flash or not, whether she's sleeping or not, whether she even knows she's having hot flashes. We see this. We've replicated this many times. However, these autonomic nervous system changes, while probably not great, do not explain the relationship between the hot flashes and our vascular indices. So we have more work to do around mechanisms, and we are doing that work. All right, let's get down to brass tacks. What about clinical cardiovascular disease events? Heart attacks, strokes, cardiovascular disease mortality, heart failure. Now, one of the issues with studying menopause or menopausal events in relation to cardiovascular disease, which is happening at 65 plus, so you have menopause happening in early 50s, those symptoms when they're peaking, the heart attacks and strokes, usually around 70. So you need these massive longitudinal studies to be able to tie these two things together using prospective measurements, which is what we like to do. One of the few studies that have these data is SWAN. So we found in SWAN that women with more frequent vasomotor symptoms at baseline, when they're in their between 42 and 52, these women have elevated cardiovascular disease events 20 years down the road. Controlling for cardiovascular disease risk factors, and we had endogenous estradiol measured almost annually, controlling for that as well. We also found that the women with more persistently frequent vasomotor symptoms have, so it's more visits that you're reporting those frequent vasomotor symptoms, again, higher cardiovascular disease risk. And we're seeing about a hazard ratio of about 1.8, so 80% increased risk, controlling for our cardiovascular disease risk factors. Okay, so I've talked a lot about hot flashes. What else is going on during menopause? Sleep. Massive issue for midlife women. Over 60%, 50 to 60% of women will report problems with sleep during the menopause transition. And we know from SWAN that those reported sleep problems, different kinds of sleep problems, trouble falling asleep, waking up during the night, waking up early, you have a 2.5 increased odds of having sleep problems during the perimenopause and early postmenopause relative to the premenopause. So these things go up as you transition through these stages. And this is controlling for vasomotor symptoms. We also, in Ms. Hart, using our wearable technologies, which we like, we have actigraphy measurements of sleep. And we like these because women don't have to try to remember what was going on with their sleep that night before. We are measuring it. And what we found was that the shorter your sleep, the higher your carotid atherosclerosis. So in the left-hand panel, this is 5 or fewer hours of night of sleep. These women, this is objectively measured. You have increased carotid plaque. This is controlling for sleep apnea, blood pressure, obesity, sleep medications, etc. These women thought that they were sleeping 6 hours. So if you have a midlife woman comes into your office, she says she's sleeping 6 hours, it's probably 5, and the vasculature can tell the tale. And we know from our large epidemiologic studies too at other times of life that short or disruptive sleep is associated with cardiovascular disease events as well. But I'm really interested in these midlife women because this is a time of vascular vulnerability and short sleep. So this is an important thing to pay attention to. We also see a more pro-inflammatory profile among these women with more disrupted sleep. And you may wonder, what about the hot flashes that these women are having? That's happening at the same time. And actually, we had a debate. Do hot flashes really matter for women's sleep? Our objective measures didn't always show that. But we actually did in Ms. Hart. These hot flashes were associated with awakenings. When you look at a minute-by-minute fashion with those physiologically assessed hot flashes and objectively assessed sleep, you see this awakening. But the hot flashes did not explain the relationship between short sleep and poor vascular health, but there was in fact a synergy that if you had above the median number of hot flashes in the sample, so 2 or more hot flashes that night, and you had short sleep, your vasculature looked particularly bad. Okay, so what about the brain? We know that the heart and the brain are very closely tied, and oftentimes what we see with the heart, we also see with the brain. So more recently, we've moved into the brain world and asked about what these symptoms mean for women's brain health. We heard from Nana Sotoro talked about verbal memory declines during the menopause transition. These are, again, Neil Epperson's data. And Pauline Mackey's data showing that women with more vasomotor symptoms have significantly poorer verbal memory as well. These are memory for names and lists and things that involve words. Pauline Mackey and I teamed up, and we recruited 20 of these Ms. Hart women, had them undergo neuroimaging, and found that these women with the more sleep hot flashes, these objectively measured sleep hot flashes have greater white matter hyperintensities in the brain. So this is a marker of small vessel disease in the brain. So what we're seeing in the periphery, we're also seeing in the brain. We set up the Ms. Brain study, and we are just crunching these data right now. We finished data collection maybe a month ago. Stay tuned about the hot flashes, but I can tell you from Ms. Brain that we do see shorter sleep or disrupted sleep associated with great white matter hyperintensities in the brain, controlling for those vasomotor symptoms. So both sleep and the vasomotor symptoms likely matter for brain health. Okay, so what are we doing now? We now have Ms. Brain 2 that was just funded, and we are just hitting the field. We're using ultra high power neuroimaging to get this beautiful cerebrovasculature. Stay tuned, we're just starting this. It's a 5-year study. We're also looking at mitochondrial mechanisms. SWAN, we were just refunded with a U19 grant to bring these women back. We're also hitting the field in the next month or so, bringing those SWAN women back, focusing more on cardiac health, as well as cognitive function and physical function. So we got a lot going on in the lab. So in summary, menopause is a universal experience for women. These vasomotor symptoms, they last for a decade or more. Are these really just this benign quality of life issue? We actually find them as a potential marker of degrading cardiovascular and brain health. Poor sleep also has implications for women's cardiovascular and brain health that may be synergistic with those vasomotor symptoms. Clinically, what are the implications? If you have a woman with a lot of vasomotor symptoms and poor sleep, these are major quality of life issues. They're going to impact her mood and her functioning, and they're very important to treat for that reason alone. However, we do not know whether treating those symptoms will improve women's vascular health, we hope, or brain health. We hope to be able to do that work. But these women do deserve close clinical management, not only for things like mood and functioning, but also those vasomotor symptoms may be telling us something, for example, about a woman's vascular health, and we really need to be on top of cardio prevention there. And all of this work is with the goal of improving the mental and physical health of women as they age. Thank you so much. Okay.
We're happy to entertain questions from the audience as well as the chat. I've got a colleague, Dr. Kathy Scruggs, who's managing the chat, so feel free to send your messages that way. Those were two really fascinating talks. Thank you so much for joining us today. I'm curious, I'm trying to pull a lot of what Dr. Santoro brought up earlier today, and again, your talk, Dr. Thurston. Have you looked at physical activity and those overall measures of other cardiovascular health and prevention and the relationship with hot flashes at all?
Like whether the physical activity improves the hot flashes?
Yes.
Well, this was actually a very early interest of mine because I am a behavioral medicine person, so I very much believe in the value and the importance of health behaviors for managing many things. And I was hopeful that physical activity and aerobic exercise would improve women's vasomotor symptoms, but sadly it does not. These vasomotor symptoms are thermoregulatory events. So when you increase your core body temperature, you actually, sweat. So you actually can trigger a hot flash in that way. And we moderate physical activity. There was the Ms. Flash studies that were done showing that it did not improve women's hot flashes. I still think there may be something to do here when it comes to higher intensity physical activity. I have some ideas in that realm, but nobody's tested them yet, so I'm not going to.
I was thinking of that, the parallel of, if you will, the preventative efforts or measures of high levels of physical activity and perhaps Alzheimer's disease or other neurodegenerative disorders.
So we know that physical activity, there's quite an accumulating body of evidence that it's really obviously helpful for cardiovascular health, right? It's a cornerstone of cardiovascular risk reduction. But also has implications for brain health. And we know that you can, through physical activity interventions, improve many aspects, actually, of cognitive health. And you can see changes in hippocampal morphology and size with regular physical activity as well. So you can change the brain. So it's worth doing. Whether or not it impacts your hot flashes, it's good for the heart and it's good for the brain.
Perhaps
it also does help sexual health. So that we do have data that exercise will improve sexual function in women, particularly midlife women. And we know that the timing of exercise also can help with genital arousal. So it may not help everything, but we know it helps sex.
It's good for a lot of things, yeah.
We do have a question from our online audience, hoping that you could speak to any differences you've observed in women who have gone into menopause prematurely due to surgical castration.
So from the hot flashes perspective, women who've had an oophorectomy, a bilateral oophorectomy, they had pretty severe hot flashes. So their, the endogenous estradiol levels are going to drop very precipitously. So we definitely see a lot of hot flashes. There is also data to show that potentially there's increased cardiovascular disease risk too among women who've had an early premenopausal bilateral oophorectomy, although that may matter whether or not that they've had estrogen therapy subsequently. And I'm not sure on the brain data. Actually, there is some information on brain too, that it's not ideal for your brain health.
Dr. Kingsberg.
We certainly have data that surgically menopausal women have higher rates of hypoactive sexual desire disorder. They're certainly at risk for genitourinary syndrome of menopause, which can increase pain, and we certainly would want them treated for that. But when we look at, for example, the WISHES study looked at naturally menopausal women versus surgically menopausal women, and the surgically menopausal women had a much higher rate of sexual desire disorder, likely because the ovary is producing 50% of circulating testosterone, and if you suddenly take it away, you're going to have a noticeable effect versus naturally menopausal women who are still producing some testosterone in those ovaries.
You mentioned that the two medications that are currently available to women for sexual dysfunction were initially tested, and the FDA approval was specifically for a premenopausal population. Those boundaries are oftentimes broken in clinical practice, and I'm wondering if there have been any reports, studies, case series on the use of those medications in the postmenopausal woman, or what might be out there for the postmenopausal woman in the future.
Well, flibanserin has been studied and published, because I've published on flibanserin in postmenopausal women. So that data is out there, that it is safe and effective. It just is not approved, so there's no indication to be able to use it, so it's off-label. Bremelanotide has some data in early phases that it was studied in postmenopausal women and also in men. Both have been studied in men as well, but not enough to give you any data. But off-label, both have been used effectively. There is no physiologic reason why it would not work in postmenopausal women for either of them. They are non-hormonal medications. So, I would hope that at some point both will be available for post, but right now there are some trials underway where we have a topical sildenafil trial for arousal disorder that's underway for premenopausal women as well. And there are one or two trials coming down the pike, for example, MDMA and psychotherapy combination for hypoactive sexual desire disorder. So, we are well behind the research on male sexual dysfunction, but my hope is that there will be support for research for women.
So I was curious generally to both of you about the relationship with autoimmune disorder, and specifically for Dr. Thurston about Raynaud's syndrome, which we know, although it appears in women often very early, there's a lot of women in their 40s who get Raynaud's syndrome, and whether there's any correlation between that population and the symptoms that you're seeing, and whether that could be a very early indicator of risk for CDD.
That's a great question, and I think about that with sort of endothelial dysfunction, et cetera, and we don't know. We just don't know. I oftentimes get questions about Raynaud's and migraine too, and we have some new data on migraine and vasomotor symptoms that there is a link there, but I do not know of anybody who's done work on Raynaud's and the hot flashes.
We have another question from the audience.
A quick question. In the phase 3 trial of bremelanotide, about 40% of the women became nauseated within 20 to 30 minutes of injection, and about 25% vomited. I would think that would provide the original approach avoidance dilemma. How well used is it?
Well, in the 40% of women who've reported nausea, 92% of them stayed in the trial, so there were only 8% that dropped out. So there wasn't as much avoidance. Most of them found that it was mild, and it went away within the first hour. So they have a 16-hour window. Women are smart. They figure out, if I am going to be nauseous, I'll plan my sexual encounters to avoid that hour. Most of the women had it once or twice, it then went away. If they persisted, they either took Zofran or waited the hour. I'm not sure 25% actually vomited. I think it was a lower amount. I think it was much lower amount. And honestly, those women would not take it. Women are smart. If the side effects outweigh the benefit, they're not going to take it.
So amongst the women who did find it an effective intervention, what was the response? How was it quantified?
Well, how it's quantified for an outcome measure is using female sexual function index, desire, which is asking about whether your desire is increased and how intense is your desire. But clinically, what women will say is, and these are women who have no desire, they go from no desire to some desire. And so some of the pushback on its efficacy is, well, it has a modest effect. Well, for the women in my practice and the women in the trial, modest was meaningful to them. They went from not having any desire to being able to have, I'm not just doing it because my partner wants it, it's because I've actually had the thought or the idea. And desire is not about frequency, it's not about whether you act on it, it's about your appetite. So again, looking at the outcome measures, the way the FDA sort of used outcome measures was based on male trials, saying, how satisfying was your sexual event? Well, desire is about wanting, it's not on activity. So I think that as we're learning about how to do better trials and research in sexual dysfunction, if you're looking for desire and changes, you're looking to measure desire, not how often you have sex.
Yeah.
So we have another question from our online participants directed towards Dr. Thurston. Can you speak to the impact of diet on experiencing or influencing bothersome hot flashes?
Absolutely. So we once had a soy hypothesis that if you ate a lot of soy, then you could improve your hot flashes. And we used to think that Asian women didn't get hot flashes, and part of the reason they didn't get hot flashes is because they ate a lot of soy. We have found that neither of these things are probably entirely true. Asian women living in the United States do get hot flashes, just at lower rates, maybe 50% as opposed to the 70% for white women. And the soy hypothesis for the average woman has not really borne out. The caveat to this is if you are an equal producer, which is a certain enzyme in your gut, you may metabolize that soy in a specific way that may have some estrogenic effects. But there's a lot of ifs, and on average, when you average over the population, our randomized trials, the last I checked, were somewhat disappointing. So the soy hypothesis is not exactly borne out, but maybe it could work for some subsets of women. Other dietary factors, women tell me all the time if they have a glass of red wine, they say, if you want to provoke my hot flashes in the lab, just give me a glass of red wine. We have not done that. I do not know of any studies that have done that, but that is what I am told. Our research has not necessarily borne that out. And then there's the final part of the diet question, which may be a little bit more indirect, but how does obesity and weight impact hot flashes? And that's an interesting story in that more body fat, which obviously, a certain diet will yield more body fat, folks will have more hot flashes pre and early perimenopausally. That relationship will oftentimes flip postmenopausally when that body fat becomes the only source of the estrogen. So just so you know, those of you who are maybe were told that heavier women won't get hot flashes because the peripheral conversion into estrone and body fat, that does not really apply to pre and perimenopausal women, and maybe just weakly in postmenopausal women. So that's my long diatribe.
That was wonderful.
Yeah.
Thank you very much. We're 2 minutes post time, so I want to thank you both for joining us here today.
Right.